ريم حركي. Next slide. Okay, so our objective today is to Okay, so our objective today is to mention the definition, type, indication, and complication of a blood transfusion. Starting with the definition. A blood transfusion is a common, safe medical procedure in which a healthy blood is given through an IV line that has been inserted in one of the blood vessels. Blood transfusion is a life-saving procedure that can be replaced and can replace blood loss, but it may lead to fatal hemolytic transfusion reaction if we do not test the blood. Tests that must be performed, of course, prior to the release of RBC's component, including EBO, RH typing, antibody screen, and compatibility testing. Okay, the blood grouping. The blood group are also known as blood type, are referred to the EBO and the RH antigen found in the RBCs or expressed on the RBCs. EBO and the RH typing are required every time red cell transfusion is ordered. Why do we do it? We do it to determine the presence of this antigen on the patient RBCs. Because if anyone who lacks this antibody or this antigen will form antibody against this antigen, and it can lead to severe hemolysis. Okay, so the EBO blood group system, it is responsible for 4 major types, as we know. Okay, we have O, A, B, and AB. So in the O, we'll have no antigen, but we'll have 2 antibody, which are A and B. Because it lacks any antigen, type O can only receive a blood from type O, but it can give a blood to any blood group. That's why we call it universal donor. On the other hand, type AB, it will have both A and B antigen, but it lacks any antibody. That's why AB can actually receive a blood from any blood group, but it will only give a blood to its type. That's why we call it universal recipient. In the type A and type B, type A will have type A antigen and type B antibody. And the type B will have type B antigen and type A antibodies. Can anyone guess type A and type B receive blood from which group?
From both, I think. From all.
A receive from O and also A himself,
Yeah.
and B برضو the same story.
Yes, okay, excellent, Farah, thank you. Component. Okay, next slide, please. Okay, so we also have another definition, which is known as a cross-matching. Cross-matching, it is also known as compatibility testing. It is done when we have a 2 compatible unit of RBCs that has been chosen. We will do it just to make sure it is compatible or not. What we will do is that we will take the patient plasma and the donor RBCs, we'll mix them together and we'll see the result of the reaction, if it is compatible or not. Next slide. Okay, so as you can see here, as you can see here, we can have 2 results after mixing the patient plasma and the donor RBCs. Either we will have agglutination, which is agglutination would indicate in hemolysis, or no agglutination. If there's no agglutination, this indicates no the patient can be safely transferred with the EBO RH compatible blood. Okay, next slide. Okay, now with the type of a blood transfusion, we have Reem will talk about the indication, but we have a whole blood, we have packed RBCs, fresh frozen plasma, and the platelets, and lastly, cryoprecipitate. Next slide. Okay, so Reem will talk about their indication, but I will mention the test needed for each type. So with the whole blood, we will have EBO must be identical and the cross-matching is required. Same with the packed RBCs. With the fresh frozen plasma, there is no need for cross-matching, or the RH typing is not important here, but the EBO compatibility is required. Next slide. With the platelets and the cryoprecipitate, they are the same. EB group compatibility is preferred, but they are not but it's not required. RH typing is unimportant, and no cross-matching is required for both types. That's it about my part. Now Reem will continue. Thank you for listening.
Assalamu alaikum. Good afternoon, everyone. I am Reem Al-Batshan, and today I will talk about indication and complication of blood transfusion. As Ghaida explained to you, there is many types of blood we can transfusion to our patient. Maybe you ask yourself now, when I can use each type. So I will explain it to you. The whole blood, we can use it preoperatively when we expect there will be large loss of blood, platelet, and bleeding factor. Also, we can use it during mass casualty or in military operation. What about the packed RBC? We can use packed RBC when there is low hemoglobin, red cell count as in anemia, or when there is a fitness of hemorrhagic shock or acute hemorrhagic with hemodynamic instability. But you must keep it in your mind, not in chronic or pregnancy anemia. Did you remember what's the treatment for chronic anemia? Anyone can remember?
Iron.
Yes. Also, there is
and erythropoietin.
Yes, you are.
Erythropoietin.
Yes, you are, all of you are correct. Now, what about the fresh frozen plasma? We can use it when your patient have deficiency of coagulation factor, and when you do coagulation test, the result is abnormal in presence of active bleeding, or when you're planning for surgery, and when you do coagulation test, there is abnormal result. What about the platelet? The clinical bleeding occur with platelet count less than 50,000 millimeter cubic, and maybe when there is thrombocytopenia. And the last one, which is cryoprecipitate, as you know, it's contain factor 8 or von Willebrand factor and fibrinogen, and we use it to correction clinical coagulopathy with fibrinogen less than 80 milligram per deciliter, and when we expect fibrinogen deficiency after massive blood transfusion of other product of blood. What about the complication? And the complication, as you know, every procedure has a complication. What about the complication of a blood transfusion? There is the complication we have, which is febrile non-hemolytic transfusion reaction. Your patient will come to you after 1 to 6 hours of transfusion with fever, but not high fever, just only just 1 degree high fever. And this happen, why? Because as you know, will be reaction between the recipient plasma will contain antibodies to leukocyte in donor unit, especially in packed RBC and whole blood. And the other complication we have is bacterial contamination, and this is non-immunological reaction. Your patient will come with high fever, chills, hemodynamic change, DIC, emesis, diarrhea, and hemoglobinuria. And the other complication is allergic reaction to donor component. Your patient will come with rash, hives, and itching. And the other one, which is transfusion associated circulatory overload. This happens with old patient when we do large volume transfusion to old patient with congestive heart failure. And your patient will come with non-cardiogenic pulmonary edema. The other complication is the transfusion-related acute lung injury. In this, your patient will come with acute less than 6-hour hypoxemia, bilateral infiltrate on chest X-ray, tachycardia, hypotension. And why this happen? It's occur when donor antibody attack the recipient leukocyte. This leading to immune complex. This deposit in pulmonary capillary beds. And before the last complication, we have hemolytic reaction and can be acute or delayed. And in acute, your patient will come with fever, hypotension, DIC, hemoglobinemia, hemoglobinuria, renal insufficiency. And in the delayed type, patient will come with anemia, indirect hyperbilirubinemia, decrease hepatoglobin level, and positive result on direct comp test. Also, we have complication, but it is rare, blood-borne disease. We have like virus. The most common, it's hepatitis B virus, and the HIV, but it's very rare. It's 1 to 2 million. Can you imagine that? And we have also chance for get hepatitis C virus, cytomegalovirus, Epstein-Barr virus, and in the bacteria, the most common is brucellosis and very rare syphilis, and also malaria can happen, and the most common one is Plasmodium malaria. Now let's go to the summary. As we know, blood transfusion is life-saving procedure, can help to replace blood loss, but may lead to fatal hemolytic transfusion when we don't test the blood. And there is different type of blood transfusion that include whole blood, bucket RBC, fresh plasma, and platelet, and the last one, which is cryoprecipitate. The decision of transfusion of RBC is based on patient hemoglobin level, hemodynamic state, and comorbidity. And one of the complications of transfusion is hemolytic reaction. And as we know, it can be acute or delayed. And the most common blood-borne disease is hepatitis B. This is our resource. Any question?
Thank you.
Thank you for listening.
Today, inshallah, myself and Yasmin will talk about deep vein thrombosis or DVT. Next, Yasmin. Our objectives are definition, pathophysiology, risk factors, management, prevention, and conclusion. Next. First of all, before we define what is the DVT, why we need to know about the DVT? Because simply can happen to anybody and cause serious illness, disability, and even death. But thanks to God, it's DVT. DVT or deep vein thrombosis is medical condition that occurs when blood clot form in the deep These clots usually affect or occurs in the lower limb, but also can affect the arm. Next. Next, Yasmin. Next. Okay.
أنا سلايد باثوفيزيولوجي يمكن ما تغير عندك.
نورة، إذا تتكلمين ترى صوتك مو واضح.
صوتي واضح الآن؟
الحين واضح بس قبل شوي لا.
Pathophysiology is the diagram shows أنا قاعد أشرح له. Stasis, vessel wall injury, and hypercoagulability. Okay. This factor increases the risk of thrombosis. When these three okay, will the thrombosis risk become more. Next, Yasmin.
نورة ترى متغيرة عندنا سلايد اللي هي باثوفيسيولوجي.
Venous is inactive, okay, or caption. Why anesthesia induction? Because and also the anesthesia facilitation of the vein. Anything because the
نورة ترى ما في صوت.
واضح الصوت بنات.
نورة
يقطع لسه.
لا يقطع. نورة وش رايك أدق عليك بالجوال وأفتح السبيكر وتتكلمين وتشرحين؟
اوكي معلش. اوكي
ترى باقي 9 دقائق على الميتنج ويقفل من عندي.
معلش اوكي طيب نلغي الجلسة ونعيدها ولا ايش؟
لا كملوا، بس انا قصدي انه باقي 9 دقائق حتى لا تتفاجئوا لو قفل. طيب
اوكي
بس نورة عندك الانترنت شكله ضعيف لانه
مرة الدكتور.
ما في مشكلة اهم شيء بقول لك يعني انت ضعيف، لكن على كل الاحوال كملي الله يحفظك كملي.
Okay. So as I said, venous stasis. What is the factor causes venous stasis? Like an activity, cardiac factor such as congestive heart failure, anesthesia induction, anything cause endothelial injury will cause interrupt the blood flow. So this is seen in the operative procedure. Hypercoagulability seen in medical conditions such as cancer, pregnancy, and inherited hematologic disease. Next, Yasmin. Okay, who at risk to have it? Next, Yasmin. Risk factor, if the patient older than 40 years, malignancy, pulmonary embolism, obesity, major surgery, trauma, pregnancy, oral contraceptive, hormone therapy, and physical inactivity. Thank you guys, and Yasmin will complete with you. And sorry for interruption.
Okay, hello everyone, I'm Yasmin Al-Fawzan. Now we will continue on with the treatment once a DVT is diagnosed. So once the patient is diagnosed or confirmed to have a DVT on duplex imaging, he should be rapidly anticoagulated. So basically the treatment of DVT is primarily by anticoagulation, and there are some advanced therapy for special situations. So for the anticoagulation, there's an initial parenteral anticoagulation for the first few days, and then a long-term anticoagulation for 3 months or more, depending on the risk factors for each patient. Okay, now let's start with the options for the parenteral anticoagulation, which is about 5 to 10 days. Mainly, we use the low molecular weight heparin in mostly all the patients, even for pregnant women, for patients with normal renal function, as it's contraindicated in renal failure, in liver diseases, and even in malignancy. But so if there's a patient with renal failure, it's better to use the unfractionated heparin. Also for patients with high risk of bleeding. Another special situation is patients who have what's called the heparin-induced thrombocytopenia, which is a condition. So that makes heparin either low molecular weight or unfractionated contraindicated for them. So we can use the fondaparinux, which is a factor 10 inhibitor. For long-term anticoagulation, after these few days, the patient should continue on the direct oral anticoagulants. It's the first-line therapy. It has many advantages over warfarin, so he can be continue on direct oral anticoagulant or warfarin. It's better, or the first line is oral anticoagulants, as it's like not required for. There's no regular monitoring parameters required, unlike warfarin, and it's associated with a lower risk of major bleeding. But however, it's contraindicated in pregnancy. Warfarin is the second-line therapy. It's required bridging therapy with heparin, so it should be started earlier. And there's a dose adjustment to maintain a target INR or international ratio of 2 to 3. For pregnancy, it's like controversial. We can use we can use the unfractionated heparin. Okay, there are some advanced therapy. They are not generally needed unless for special situations. One of these is the catheter-directed thrombolysis, which is basically insertion of a catheter and injecting special agents or thrombolytic agents like streptokinase and plasma activation, and that will destroy the thrombus and will provide a rapid relief of the symptoms. It's indicated in limb-threatening ischemia or acute cases. However, it has several contraindications. For example, patients who have a high risk of bleeding, so thrombolysis is contraindicated for them. So another option is thrombectomy. It's indicated as an alternative for catheter-directed thrombolysis. So for patients with high risk of bleeding, basically it's an insertion of a catheter with a bag and which will take off the thrombus directly. Another option or preventive method, we can say, it's the inferior vena cava filter, which is a filter that is inserted in the inferior vena cava. It's actually not a treatment for deep vein thrombosis, but a prevention for patients with high risk of pulmonary embolism. So to prevent the fatal embolus that can form, especially for patients who are contraindicated for anticoagulants. So we put this as a prophylaxis for major or fatal complications. Until, like it can be temporarily, until patients can reuse the anticoagulation or the risk is reduced. Okay, now prevention of deep vein thrombosis. So it's we can suspect the risk of DVT for patients, so we could prevent the condition before it's formed. There are several preventive methods, especially for patients who will undergo operation or surgical operations. We can divide them into general preventive measure, pharmacological, and mechanical. For general, it's for example, the main one is early post-operative mobilization, which provide or really reduce the risk of developing a DVT. It's suggested for all the patients at all risks. Pharmacological treatment include a low molecular weight heparin, unfractionated heparin, and oral anticoagulants. Warfarin in generally is not used for prophylaxis. For mechanical, we have two types of evidence-based mechanical prophylaxis. One is called the graduated compression stocking, as you can see this in this picture. Also, what's called the intermittent pneumatic compression stocking, as you can see in this picture. But however, so there are several preventive methods, but for which patient group should we use each one? So they are not usually used for all the patients. So a risk calculation must be done, a risk of thromboembolism and a risk of bleeding. And this will be adjusted for each patient group depending on the risk. So I will give you two cases. For example, a patient who is 17 years old who will undergo a minor surgery, and another patient who is 70 years old with a hip fracture, maybe malignancy, and a previous DVT is different from the younger one. So some operations will not need any prophylaxis except for early mobilization, and other will need all of these. Okay, for intermittent pneumatic compression, it's like inflation, deflation, compression with the to mimic the calf pump mechanism of walking. This is
ياسمين سامحيني بس لو قطعت كلامك. الآن شكله راح يفصل الآن شوي الميتنج، إذا فصل ترجعوا لنفس الرابط بس عشان نكمل، لأنه أتوقع إنه باقي عندك قليل وتخلصي.
risk calculation for each individual. We can divide them for three categories: low risk group, moderate risk group, and high risk group for developing DVT. Low risk group include patients who are less than 40 years of age, who can be ambulatory or mobile after surgery, and minor surgeries. In general, the prophylaxis is usually encourage early ambulation is enough. In general, ambulation in all patients in all risk groups is encouraged. Also, the intermittent pneumatic compression can be used for special situations in low risk. For moderate risk, patients who are over 40 years, for abdominal pelvic thoracic surgery, along with ambulation, we can suggest giving them low molecular weight heparin or unfractionated heparin, which is usually given subcutaneously before pre-operatively and post-operatively for 1 week or up to 3 weeks, depending on the patient's specific situation. Depending on this type of surgery, the mobilization after the surgery. But for the mechanical prophylaxis, is just until the patient can regain mobility. For high risk individuals who are over 40 years, who have prior DVT or pulmonary embolism, for malignancy surgeries, orthopedic surgeries, especially hip and pelvic, also for a patient who with hypercoagulable states. We recommend them all the prophylaxis, the pharmacological, and also the mechanical prophylaxis. So now, that's it for the treatment and for the prevention. If you can continue, Noura, if you regain your connection.
No, Yasmin, continue if you can.
Okay. In conclusion, deep vein thrombosis is a medical condition. Basically, when a clot forms in the deep vein, the pathophysiology is with the virtuous triad. Can anyone remind us of what's the virtuous triad? Noura, if you can.
Stasis, hypercoagulability, and endothelial injury.
Yes, and the primary treatment is with anticoagulation for up to 3 months or more, and mechanical and pharmacological prophylaxis are suggested to be used according to the patient's risk. These are our references. And thank you. If you have any question, feel free to ask.
Thank you so much.
Thank you so much.
شكرا، الله يحفظكم. حقيقة أيضا البرزنتيشن جدا مهم وممتاز، يعني حقيقة معلومات مركزة وممتازة. طبعا نفس الشيء الدي في تي بالنسبة للجراحة. طبعا في كورس الجراحة يعني أكيد لا شك المواضيع اللي بتاخذوها لازم تكون لها أهمية قصوى يعني. ولكن الدي في تي أيضا من الأشياء المهمة جدا، خاصة في الجراحات الطويلة والجراحات اللي تحتاج إلى أن المريض يكون نايم على ظهره بعد العملية لفترة معينة. بتكون في هناك عندنا يعني خطورة على المريض. لذلك دائما اللي منكم راح يتخصص في الجراحة حتى تسمعوا دائما بعد ما تخلص العملية، خاصة إذا كنت أنت مثلا التيم ليدر أو بالاستشارية الخاصة المسؤول عن المريض، حيجيكي الموجودين في القسم عندك والدكتورة متى نقدر نبدأ مثلا الأنتي كواجولانت مع المريض، إذا كان مثلا المريض أصلا ياخذ قبل العملية، إذا كان ما ياخذ قبل العملية. فهذه معلومات مهمة. طبعا أنتم أخذتوا الآن فكرة عامة عن هذا، بس بعدين لما حتدخلوا في كل واحد وتخصصه طبعا حتبدا تصير الامور امامكم يعني فيها عمق اكبر، وحتبداوا يعني تعرفوا والله هذا ايش اعطي له، هذا ايش ما اعطي له، متى اعطي اصلا، متى ما اعطي. لانه في عندنا من الجهه الاخرى صح انه نقدر نعطي انتي كواجلنت عشان يعني تبريفنت يعني الدي في تي، ولكن من الجهه الاخرى ايضا لابد الانسان يكون حذر، لانه عندنا بليدنج بعد العمليه ممكن يحصل ايضا. اذا اعطينا انتي كواجلنت بدري ممكن يحصل بليدنج عند المريض ويدخل في مشاكل ما نبغاها. على كل الأحوال يعني ممتاز حقيقة يعني I'm proud of you، وممتاز، وصلى الله عز وجل إن شاء الله يحفظكم كده وتكملوا على هذا نفس المستوى. وأراكم إن شاء الله كده قريبا بإذن الله سبحانه وتعالى في البيت سايد تيتشنج، ويعني